My name is David Frame, and I just want to add a personal comment here. I was recruited here about 8 years ago, primarily to do bone marrow transplant, and I have been adopted very luckily by this immune heme group. And I will tell you that I have never seen two more dedicated, professional, compassionate, and passionate physicians than Dr. Walkovich and Dr. Connelly. And it has been a true pleasure to have a very little part in this clinic that I think has really, as Dr. Boxer said, really has set up, I think, a very wonderful model for how medicine really should be, and that is a true multidisciplinary model. So I really want to commend the work that these two have done. In any place to do this, it is extremely difficult. Here it's even a little bit more difficult, and they were able to do it almost seamlessly. So it was pretty amazing. All right, so today, this session, we're going to start with Dr. Connelly with a very interesting patient from Oman to Ann Arbor, Dyskeratosis congenita.
Thanks, David, for that nice introduction. And, you know, I would echo the same things about David. He has, I always feel I have a 10% of the passion that David has for taking care of patients. So for him to say those nice words means a lot to me. So David has been a integral part of our program as well, and is heavily involved in a lot of our cases. And it's been a lot of fun with all the members of our team. So let me get started on this case. And so for those of you who don't know where Oman is, let's get my pointer here. So here's Oman here. It's just east of Saudi Arabia. And from what I hear, it's quite nice. Our patient taught us quite a bit about Oman here. Here's one of the beautiful beaches they have there. And so part of this talk is why would someone leave this for this, which is a pretty common scene I think all of us are pretty familiar with now. But let's begin to the beautiful shores of Oman. So our patient originally presented at age 6 with pallor. Counts weren't done at that time. He was just placed on iron supplements. It wasn't until he was age 8 that he was found to have low normal counts in all 3 cell lines, white count of 4, hemoglobin 11, platelets of 150. At age 9, platelets began to decrease, and testing for Fanconi's anemia was negative. A bone marrow was done at age 10, which showed hypocellularity, and he was placed on an anabolic steroid for 6 to 7 months. He actually had improvement of counts, but this was discontinued secondary to elevated liver enzymes. Further workup was negative for autoimmune and infectious causes. He was actually felt, despite this workup, about to have Evans syndrome, which is an autoimmune cytopenias in at least two of the 3 cell lines, and so he was given prednisone and IVIG, which also had some improvement with the prednisone, but he developed avascular necrosis of the hips, which is a risk factor by itself in patients with Dyskeratosis congenita. So the family is frustrated that he was developing problems from his therapy, and therefore they took him off therapy, and they, in their words, put him in the hands of God. But counts continued to decline. He's placed on another immunosuppressant with no response. His past medical history was significant for brittle nails. He had a geographic tongue, but no really true white plaques. Family history was very positive. He had a great-grandmother with anemia, an uncle with idiopathic fibrosing alveolitis and thrombocytopenia that developed at age 33, and a paternal uncle with hepatic cirrhosis. And of note, these were all on the paternal side. Physical exam was grossly unremarkable, and so this is when our patient came to us. So the question is, where do we go from here, or really when? So let's go back in time, so how we're able to link bone marrow failure with telomeres. And so this begins back with Hayflick in 1965, demonstrated that fibroblasts do not have an unlimited potential to proliferate. And so he showed that fibroblasts grown in culture had a limited in vitro growth potential. They didn't die, they just seemed to kind of freeze at the phase they were at. This later became known as the Hayflick limit. And then Watson and Olovnikov in the early 1970s described the end replication problem, and this was some very intricate work given that we didn't know the molecular pathology of DNA replication very well at the time. And so as we all know, you have DNA replication occurs in a 5' to 3' direction, so that's really no problem for the leading strand. However, for the lagging strand, that is quite a problem. And so what the body has developed is that there needs to be an RNA primer, which is known as a Ozaki fragment, and so replication can occur in the 5' to 3' direction. Those Ozaki fragments get degraded, and these DNA segments are then ligated together. The problem is, though, is at the very end of the chromosome is that when that Ozaki fragment gets removed, there's a gap. And this is a problem because over time you can start losing coding DNA. So what's the solution to the problem? Well, one is telomeres and what is known as the Shelterin complex. And so Blackburn discovered a hexanucleotide repeat at the ends of tetrahymidine thermophilia RNA. Further research eventually elucidated this complex natures of what are known as telomeres and their protective Shelterin cap. Oops. So the telomeric complex itself is made up of this hexanucleotide sequence, TTAGGG. There's a double-stranded component as well as a single-stranded 3' overhang. This is important so that when cells divide, if a small piece of that DNA is left behind, that's okay because it's not coding DNA. In addition, there's a Shelterin complex, which you'll hear quite a bit about in our next talk, which is there to help protect the ends of the chromosomes. So this is all well and good, but what happens if you begin to shorten the telomeres and they get very short, at which point you could once again approach what is known as the half-life limit? Well, Blackburn and her postdoc Greeter in 1978 also discovered what they call the specific telomerase terminal transferase activity in these same extracts. This was later known to be known as the telomerase complex. So the telomerase complex consists of a protein component known as H-TERT and a RNA template, which is known as H-TERK. The template is used to add nucleotides on into the 3' overhang, and what ends up happening is you elongate this 3' overhang. Telomerase is not active in all cells. It's active in stem cells. It's active in germ cells and their progeny, and they're active in some activated immune cells, particularly activated T cells. It's also very prominent in cancer therapy. Telomerase is upregulated in 90% of cancers. Okay, so we think we solved the end replication problem, but what happens when there's a mutation in the end, in this machinery that solves the end replication problem? So this was first seen by Lundblad in 1985, and so he found a mutation in what he called ever shorter telomeres 1, which he looked in yeast cells, and noticed that cells that had this mutation, that they had attrition of telomeres in senescence. And so as you can see here, on the southern blot on the left here, along the x-axis here is the number of generations, that is for yeast cells, and these are the plots for the telomeres. As many of you know, that the telomeres that are present in cells have variable lengths, not only between different cells, but within cells by themselves. And so you get a spectrum of telomere length that's done there. As you can see, because these cells have this mutation, they cannot elongate their telomeres, and that so under successive generations, you get shorter telomeres. What's seen here on the right is the growth capacity of these different generations. As you can see, at 25 generations, there's quite a bit of growth capacity. But once it gets to 87 generations, that growth capacity is severely inhibited. And so what they found is that these yeast cells that have very short telomeres develop into senescence phenotype. Well, why do they go into senescent phenotype? And so this was shortly discovered later thereafter in this paper in Nature, which demonstrated that what is happening is that when telomeres get very short, they actually activate a DNA damage response. What is done here is that they took human fibroblast lines that are known to have developed senescence with very short telomeres. And they took cells with short telomeres, and they showed that there were gamma H2AX foci that were primarily located at the telomeres, and that DNA damage response proteins, including 53BP1, co-localized with these gamma H2AX foci. In addition, what they were able to demonstrate is that DNA checkpoint proteins also co-localized with these gamma H2AX foci. What they also demonstrated, however, is that if cells were able to have forced telomerase expression and where they were able to maintain their telomere length and ended up proliferating, or cells that were quiescent, is that they had no evidence of these foci. And so it was really in the only cells that were developing senescence, and once again linking the DNA damage response to short telomeres in senescent cells. So how do we get telomeres in bone marrow failure with Dyskeratosis congenita? So the clinical condition itself was diagnosed in the 1900s and had this classic clinical triad of nail dystrophy, skin dyspigmentation, and oral leukoplakia. It wasn't until 1963 when the first female was diagnosed with this clinical triad that it was realized that it was more than just an X-linked disorder. And then well into the 1960s as well, as that patients who developed this clinical triad were developing bone marrow failure. The true genetics of the disease wasn't developed until the 1990s. In 1998, Heiss et al. Was able to clone the causative gene in X-linked dyskeratosis, which he termed DKC1 or dyskeratosis congenita 1, which was the gene, and dyskerin was the protein. In 1999, Mitchell and later Villemi et al. Demonstrated short telomeres in cell lines with these mutations in a large series of DC patients respectively. So this was the context that our patient was born. So we were just beginning to understand why telomeres, when they get short, they causing senescence and DNA damage response resulting in bone marrow failure, but really didn't have a great understanding of the clinical implications moving forward. So back to modern times and our current knowledge of dyskeratosis congenita. So since the initial discovery of the dyskerin related to dyskeratosis congenita, there's now a whole host of mutations which are known to result in dyskeratosis congenita. Those mutations can be found in the telomerase complex, the Shelterin complex, telomerase trafficking, telomere stability, and telomere capping capacities. But all of them have a role at the telomere structure. The complexity of the disease at the penetrance is highly variable, not even among different families, but within families themselves. The other aspect of this disease, of course, is that they have genetic anticipation, which can be seen here on the right, demonstrating that for patients who developed who passed on the mutation to the children, not only do they pass the mutation, but they pass on the shorter telomeres. So subsequent generations have shorter telomeres and tend to have more severe disease. Because we know that short telomeres are linked to dyskeratosis congenita, the diagnosis is now demonstrated by short telomeres and leukocyte populations. Okay, so now we go back to Ann Arbor, where they came here to Ann Arbor to see Dr. Boxer, like many patients around the world. This is a picture of the family. This is his father, and here's our patient here. I think this picture was taken in October, but he began wearing his winter clothes in about September to stay warm. So Dr. Boxer immediately kind of picked up with this patient with that extreme family history and bone marrow failure that this has to be dyskeratosis congenita. And I believe he told the family even before the testing was back is that this is what it has to be. And so this is a flow fish analysis looking at telomere length. As you can see here is that this patient has extremely low telomeres, this being the first percentile of populations. You can see there's an age-related decline in telomere length, but this is well below the norm. Genetic testing revealed a heterozygous mutation in H-TERT, which has been previously described, resulting in low telomerase activity. Unfortunately, the patient had two siblings which were tested positive for this mutation as well as the father. They are currently asymptomatic, and transplant was subsequently recommended. So the problem with transplant, although that is a curative, at least for the bone marrow component here, is that historically there's been very poor outcomes for patients with dyskeratosis congenita. This is one of the largest studies that have been published to date and was actually just published last year, looking at 34 patients. Again, quite a time frame from 1981 to 2009, and those of us in the field know that transplant outcomes are nowhere near where they were in 1981 that they are today. However, this is the largest series. Some things that are important to point out is that graft failure is very common in this population. 4 out of the 34 developed primary graft failure, and 6 of the remaining 30 developed secondary graft failure. And unfortunately, only 14 of 34 are currently alive. The early deaths were primarily from graft failure. Late deaths tend to be primarily from pulmonary fibrosis. So why these complications? Well, one, as we noted, is that there is increased graft failure. So why are these problems with engraftment? So this was a study which is still cited pretty commonly that, and as we learn more about bone marrow failure syndromes, is we're realizing it's not just a stem cell problem, that there can be problems within the bone marrow niche as well. And so what this group did is they took, in this experiment that's shown on the left here, is they took wild-type cells, hematopoietic stem cells, and put them into irradiated mice that have either homozygous or heterozygous TERT mutations. As you can see here on the left, is that when they transplanted into a 2-month-old mice, that the reconstitution of the bone marrow was pretty equal between the heterozygotes and the homozygotes. However, when they did this at 12 months of age, they saw that the ability to recapitulate the bone marrow was significantly reduced in the homozygous TERT mice. They went further to do more additional experiments looking really at the mesenchymal stem cells and the other supportive cells that are within the bone marrow, and they demonstrated that the 12-month age old mice had much shorter telomeres, and that resulted in dysfunctional cells with altered cytokine profiles and poor ability to support hematopoietic stem cell growth. So even if you're replacing healthy stem cells into our bone marrow transplant candidates, you still have to deal with that there's an altered niche that they must grow in. How about chemosensitivity? And so this was a study done by Fred Goldman's group when they looked at the DNA damage response to DNA damaging agents. And so what this experiment has done here is that this is looking at growth potential. This is a ratio of the cellular growth versus their normal capacity when not exposed to DNA damaging agents. They use irradiation, etoposide, and paclitaxel. And what you can see here is that the patients who had Dyskeratosis congenita, which are the black bars, had significantly reduced proliferative potential compared to control cells, indicating that these cells have increased sensitivity to DNA damaging agents, and therefore that patients who are getting chemotherapy for bone marrow transplant may have increased toxicity. Well, this is actually true. Unfortunately, patients transplanted for Dyskeratosis congenita appear to have accelerated development of pulmonary fibrosis and increased risk of hepatic toxicity. So although patients may do well early on post-transplant once you get the graft in, what we're finding is that 3 to 5 years after transplant, they start developing very problems with their pulmonary fibrosis. As you know, Dyskeratosis congenita also has a cancer predisposition. It's 11-fold higher than the general population. And transplanted patients all have accelerated development of cancer, including skin, head, and neck, and anogenital. Risk factors may include conditioning therapy and GVHD development, and impaired tissue healing may also result in prolonged and/or more severe symptoms. So what's the current approach for transplant Dyskeratosis congenita? So this is a very active area of discovery right now, since our experience in this form of bone marrow failure is much less than what we know about other bone marrow failure syndromes, including Fanconi's anemia. Currently, as you would expect, given what I just told you, reduced intensity conditioning regimens with focus on reducing pulmonary, hepatic, skin, and head and neck toxicity is important. Approaches to reduce GVHD, such as T-cell depletion, are not routinely applied, secondary to engraftment risk. A lot of the approach to transplant is similar to Fanconi anemia patients, which we have much more experience in, and they have similar increased sensitivity to chemotherapy, and those, at least in our country, do get T-cell depletion since they seem to have an increased GVHD risk. However, given the engraftment risk in these patients, that is not routinely done. And of course, aggressive monitoring of post-transplant complications, including engraftment, PFTs, and skin, head, and neck exams are essential for these patients. So to end our journey, treatment was received at our center. Our patient received a reduced intensity conditioning consisting of alemtuzumab, fludarabine, low-dose cyclophosphamide, and total lymphocyte irradiation. As you would expect, you would like to eliminate radiation in these patients, but again, they have high engraftment risk, and therefore a lot of protocols are now including low-dose radiation. Total lymphoid irradiation would also spare the lung fields. Our patient tolerated well with very prompt engraftment. The patient did have a protracted course of BK cystitis, which we treated with cidofovir and actually hyperbaric oxygen therapy, and we hypothesize this hasn't been reported, but likely secondary to impaired wound healing, which is known to happen in dyskeratosis. And more importantly, as we reached into the November month, our patient returned to Oman shortly after day 100 to continue receiving post-transplant care. Our patient plans to come back and see us annually for continued follow-up. They had an amazing Halloween, and so they want to make that an annual event for their entire family to come here. And this is shortly before they left, all bundled up and ready to go back to sunny Oman. Any questions?
Thank you. We have time for one question.
What is the role for hyperbaric oxygen in BK cystitis?
Great question. So, the idea between hyperbaric oxygen, so the most common medical implication that's being used for that is in plastic surgery, particularly with skin grafts. And so the idea is that in order to get good tissue healing, part of the problem may be that you may not be able to administer oxygen readily to the area. And so the idea is to supersaturate the blood to drive more oxygen to that area. There has been There's been published reports on success of hyperbaric oxygen in patients with dyskeratosis, with hemorrhagic cystitis related to BK with success. Again, the idea is that some of these patients you can treat the virus, but they just you're having trouble healing the bladder. Our patient was complicated in how to best treat him for a lot of reasons. One, because of his underlying dyskeratosis congenita, we felt that we needed to improve his ability to heal tissue. And then two, some of the other methods that we'll use, you can do bladder installation of things like prostaglandin and GM-CSF, but that has lots of complications, can make it worse, and is also very expensive. And this family was so enamored with being here at Michigan, they paid for everything out of pocket. And so part of our treatment choices were based on that.
Thank you. So our second talk will actually follow up on a lot of research efforts in this area. And I'm privileged to introduce Dr. Maillard, who is one of our hematologists whose work in the lab really goes way beyond a lot of what he does clinically, and really has enabled a lot of our labs to increase their different types of research. So it is wonderful to have you here today to be able to do this. I'm just kind of figure out. Oh, there it is. Sorry. All right. Thank you.
So I'd like to thank the organizers for inviting me to be part of that symposium. It's been a great pleasure to interact with the newly formed Immuno-Hematology team. There's both on the science side of things, on the clinical side of things. I've received advice from members of the team. I've even seen some patients that were deemed to be really too old for the pediatrics clinic despite the Boxer rule. So it's been really a pleasure to interact with the team. So what I'm going to talk about today is work from my lab on telomerase and Shelterin defects in bone marrow failure syndromes, with a focus on one specific member of the Shelterin complex called ACD or TPP1, indicated here on this cartoon, that has an important role, is part of the Shelterin complex and in bridging the Shelterin complex with the telomerase complex. This is a project that started a bit as a side project in my lab about 4 or 5 years ago, but has really taken a life of its own in large part through a nice collaboration with Katie Keegan, a member of the Department of Pediatrics. So this is what I'm going to talk about. I'm going to introduce you to telomeres and to the Shelterin complex, basically building on what Jim did just very nicely in his presentation, and continue reviewing the role of telomerase and Shelterin mutations in Dyskeratosis congenita and bone marrow failure syndromes in general. Then I will describe the work from my lab, describing an acute sensitivity of adult hematopoietic stem cells to inactivation of the ACD-TPP1 gene. This is work that was just published a few months ago in the Journal of Clinical Investigation. And I will then review some recent data, in part from a new collaborator who moved recently to Michigan, describing dual functions for Shelterin proteins in end protection and in telomerase recruitment. And I will finish with some predictions and perspectives about what that might mean for the field. So the DNA end problem was nicely introduced to you by Jim. In part, it is related to the end replication problem that he was describing, basically the loss of genetic material on the lagging strand of telomeric ends. But there's a second problem associated with the structure of linear chromosomes, which is that the end of chromosomes would be perceived by the cell as a broken piece of DNA if you didn't have an active mechanism to prevent that from happening. And so the problems are really interrelated very much and have to be dealt with separately. The way the body solves the problem is by a separate set of mechanisms to solve the end protection and the end replication problem. The end replication problem is solved by the telomerase complex, which is a ribonucleoprotein complex, contains an RNA component, which serves as a template for reverse transcription to fabricate the missing piece of DNA, and an enzymatic component called TERT that essentially has a reverse transcriptase activity. And Dyskeratosis is a gene that is that was the first one to be discovered as responsible for Dyskeratosis congenita, as Jim mentioned, that takes part in assembling this ribonucleoprotein complex. To solve the end protection problem, the body has put together a complex of proteins called the Shelterin complex that shelters the ends of chromosome. It is made of about 7 or 8 proteins that bind very specifically either on the double-stranded portion of the telomeric ends or on the single-stranded portion of the telomeric ends. The protein that we're going to talk about mostly today is this protein called TPP1 that really bridges the double-stranded binding portion of the Shelterin complex and the single-stranded binding portion of the Shelterin complex. And then another element that I'll come back to at the end is how this complex is coupled to the telomerase complex and how it actually works to actively recruit telomerase into telomeric ends. So obviously there have been reports of mutations in mostly initially genes encoding elements of the telomerase complex, but more recently also genes encoding elements of the Shelterin complex in patients with bone marrow failure syndromes and Dyskeratosis congenita. Dyskeratosis was the first one to be identified. TERK and TERT are the most commonly mutated genes, and this gene TIN2 here that encodes for this factor here that binds the double-stranded region has also been observed as being mutated in a particularly severe form of Dyskeratosis congenita. So this was introduced to you by Jim already very well. So Dyskeratosis congenita can be defined as a telomere shortening and somatic stem cell failure syndromes. The mucocutaneous triad gave its name to the syndrome based on the presence of discoloration of the skin, dystrophic nails, and also mucosal abnormalities. It is only present in a fraction of patients and not all patients. But the most common limiting clinical problem in patients with Dyskeratosis congenita is the occurrence of bone marrow failure, as described in the boy who was presented earlier. So it's a cancer-prone multi-organ stem cell failure syndrome associated with aberrant telomere biology. As I mentioned, bone marrow failure is a dominant clinical presentation and a major source of morbidity and mortality for our patients, but by far not the only manifestations. And other organs can be affected, including the skin, the lung, the liver, and the brain, likely accounting for this increased sensitivity to side effects of transplantation that Jim was describing to you. And there are some related syndromes for the pediatricians in the room who are essentially unique or severe forms of Dyskeratosis congenita. I would like to just feature briefly this very nice work from Maria Armanios from Johns Hopkins University, who was the first one to report the occurrence of telomerase mutations in families with idiopathic pulmonary fibrosis, very often at a much later stage in life than the presentation with bone marrow failure. And you can see that in some cases patients had very severe forms of idiopathic pulmonary fibrosis, in some cases much milder, but it clearly illustrates that the disease is not a bone marrow disease, it's really a multi-organ disease that can present in multiple different ways. And in fact, it's been reported many times that pulmonary fibrosis tends to occur somewhat later in life, and in later generations in the family you have the phenomenon of genetic anticipation due to inheritance of short telomeres through the germline that creates more severe earlier effect, perhaps exactly as what is happening in the family that you just heard about. So the genetics were reviewed already by Jim. The mutations can be autosomal dominant, recessive, or X-linked in the case of DKC. Sometimes we're dealing with de novo mutations. There is very variable phenotypic expression, and sometimes with the phenomenon of genetic anticipation. So clinically, there is a need to maintain high degrees of suspicion. I would argue also in the adult population. And there's an expanding range of mutations that have been identified that for the moment cover approximately 60% of patients who have been identified to have Dyskeratosis congenita. Sharon Savage at the NCI, with whom we're collaborating, has done some of the best work to map the landscape of genetic mutations in Dyskeratosis congenita. This is a recent review of hers that describes all the genes that have been shown to be involved. So multiple different genes associated with the telomerase complex, TERK and TERT being the most common one. The TIN2 mutation in the Shelterin complex that I mentioned to you, and then some other genes that encode for proteins that have a role in telomerase trafficking, stability, and in telomere capping. And this is obviously work in progress. It is very likely that there will be other genes that are discovered, especially with whole genome sequencing efforts in patients with Dyskeratosis congenita that do not have a mutation identified so far. I also wanted to feature the work from Peter Lansdorp at the British Columbia Cancer Agency that underlies this test that you perform in pediatrics to measure telomere length in patients. So this is a flow cytometry-based test that is referred to as FlowFish, where a population of patients' granulocytes and lymphocytes are mixed together with bovine thymocytes. It's very interesting to read the Nature Protocols paper that they published where they explain how they obtain the thymocytes from the local batcher and how they process it into the CLIA certified assay. And you can see that bovine thymocytes tend to have larger telomeres as compared to the human cells, so they serve as an endogenous control. And you can detect telomere length based on hybridization of a fluorescent probe that is specific for the telomeric repeats. And then you can get these kind of histograms here that give you, as an endogenous control, as a normalizing factor, if you wish, the average length of bovine telomeres on the day of your assay. And you can compare that with granulocytes and lymphocytes of the test sample. And with that, they have established percentile curves, essentially, that give you a normal telomeric length at different ages of life. This is throughout age here. The legend has been cut. You can see that there's a normal attrition of telomere length during life that is more pronounced in the lymphocytes than in the granulocytes, probably because they undergo a higher number of replications. And if they now measure the telomeric length in a large group of heterozygous carriers of a TERT mutation, for example, as compared to relatives that are non-carrier of the mutation, you can see that all the carriers of the mutation cluster in the low range of the normal or below the normal distribution for telomeric length. Some of these carriers, I suspect, may be completely asymptomatic, just like the siblings and the father in the family we've heard about, but there's a clear distribution towards short telomeres. So to wrap up this introduction, I wanted to mention some open questions in the field of Dyskeratosis congenita that underlie some of the work that we have done. Despite the fact that we know the mutations in about 60% of the patients, there is still up to about 40% of patients with classical DKC or inherited bone marrow failure syndromes that have no known genetic defects. I would also like to argue that the clinical spectrum of Dyskeratosis congenita is much broader than it was initially recognized. So there may be other patients who do not have classical DKC who may still have mutations. And then you could also argue that dysfunctional telomeres may play a role in more physiological forms of stem cell aging and in certain aspects of cancer. So the question that we really wanted to address is whether there would be a role for Shelterin dysregulation or mutations in these syndromes, and more in general, what are the function of elements of the Shelterin complex in hematopoietic stem cells. So the Shelterin proteins have been discovered and characterized through their capacity to bind either the double-stranded or the single-stranded region of the telomeres. Individual proteins have very surprisingly specific functions to inhibit multiple aspects of the DNA damage and repair response triggered either by exposure of the double-stranded or the single-stranded region of the telomeres. And one aspect of the work when you review the literature is that the largest body of work comes really from cell lines and immortalized embryonic fibroblasts, relatively artificial systems. The embryonic fibroblasts are typically immortalized by SV40, so you inactivate P53, you inactivate RB pathway when you do that, and a lot of the biochemical work that has been done comes from these model cells with much more limited data in real tissues that matter in our patients. And so this is where the work from Katie Keegan, who's a pediatric geneticist in the Department of Pediatrics here at Michigan, came into play, because Katie really was one of the first group that looked at the role of Shelterin proteins in real tissues and in a specific context. And she focused in particular on a gene that was called adrenocortical dysplasia, because one of the phenotypes of the mice that are mutant for this gene is dysplasia of the adrenal cortex. She was working with Gary Hammer at that time and got interested in this gene when it was positionally cloned in these spontaneous mutants that they were working on. And the mice do not have only adrenal defects, they have also other phenotypic manifestations. They have reduced birth weight, skeletal, gonadal, adrenal, and renal abnormalities. And you can see here on the picture that they have also a pattern of caudal truncation that Katie is very interested in, because there are several genetic syndromes in patients where caudal abnormalities are particularly prevalent. And on top of that, they have skin hyperpigmentation. I'll show you a picture in a few minutes, and other features that were reminiscent of Dyskeratosis congenita are basically leading to the question as to whether some of the tissue-specific manifestations in this case are related to the failure of specific subset of somatic stem cells. So we came into play by asking the simple question, does ACD-TPP1 regulate the maintenance function of hematopoietic stem cells? There was no information about that before we started that work. And we thought this could be important because obviously hematopoietic stem cells are the central cell that fails in the most common manifestation of Dyskeratosis congenita. And also because there's a lot of experimental tools that we can use to characterize hematopoietic stem cells in the mouth. And we just published this data showing that hematopoietic stem cells turned out to be surprisingly acutely sensitive to dysfunction of the ACD gene. I will show you the data leading to that conclusion, with several features of the response that could not have been predicted in model cell lines. So this is work from a very talented MSTP student in the lab, Morgan Schoens, who just graduated a few months ago. So the first work that we did was focused on the spontaneous mouse mutant that Katie had identified, which contains an intronic mutation in the third intron of the ACD gene, a simple substitution from G to A that causes aberrant splicing of the transcript and the production of truncated transcripts that encode no functional proteins. It is a phenomenon that does not completely get rid of the wild-type transcript that still remains at about 2% of wild-type level, so the allele behaves as a strongly hypomorphic allele and not as a complete loss of function. And if we looked at the fetal compartments in these mice, we saw that the fetal liver, which contains the most abundant hematopoiesis in the fetal stages, had a slightly reduced cellularity, but produced normal numbers of hematopoietic progenitors as assessed with colony-forming unit assays in methylcellulose cultures, and largely preserved numbers of primitive hematopoietic progenitors. There's some technical thing here in the slide that prevents you from seeing the dot plots very, very well, but we're basically looking at lineage negative cells that express high levels of the stem cell factor receptor c-KIT and the stem cell antigens CAR1, and then express this unique pattern of SLAM markers that Sean Morrison described 7 or 8 years ago, identifying the compartment of long-term hematopoietic stem cells. And you can see that the numbers of long-term hematopoietic stem cells in the fetal liver are largely preserved number-wise. So the stem cells are made, and they expand during fetal life with no major problems. However, if you take these stem cells and you subject them to a transplant in a competitive fashion, this is done here using ACD mutant fetal liver in competition with wild-type bone marrow, or wild-type fetal liver in competition with wild-type bone marrow, using congenic markers that allow us to track the origin of the recovering hematopoietic cohorts, either from the tester population or the competitor population in a lethally irradiated host. You can see that the wild-type fetal liver reconstitutes a high proportion of the myeloid T-cell and B-cell lineages in the host, but the ACD mutant fetal liver is very, very deficient at providing this reconstitution. And that is consistent with a very profound defect in stem cell function. If you look at the stem cell numbers at the end, you see completely abrogated reconstitution in the stem cell compartment. Now, this was a phenomenon that could still have been explained in principle by problems in the hematopoietic stem cell niche, at least in part. So to address that question and also to look at the overall effects of lacking ACD-TPP1 in these cells, we started studying a conditional knockout allele generated by KD that gets rid of the entire internal exons 3 to 8 of the gene through the poly-IC-activated MX3 transgene, giving rise to completely null allele. And when we did that in adult mice, we observed a very acute phenotype in the hematopoietic compartment only days after loss of the ACD-TPP1 expression. We saw a complete collapse of the hematopoietic compartment. You can see that the cells here in this quadrant completely disappear or are markedly reduced already 5 days after activation of the CRE transgene and inactivation of the ACD-TPP1. This was much faster than anybody would have predicted based on model cell lines in the past. Now, this is something that was still achieving ACD inactivation in more than just the bone marrow. So to really address the cell-autonomous function of ACD-TPP1 in the bone marrow compartment, we made use of bone marrow chimera again, where we established mixed bone marrow chimeras with tester marrow, either ACD, conditional knockout, or control, in comparison with competitor wild-type cells. We established the chimeras to a pretty even chimeras on baseline, and then we deleted ACD-TPP1 and looked only 4 weeks later or 2 weeks later, and we saw a complete loss of contribution to the myeloid cells in the compartment here identified by CD45.2 expression that contain the cells derived from the conditional mutant mice. You can see here this contribution to the peripheral compartment graft over time. Already 2 weeks after deletion of ACD-TPP1, there was a complete lack of contribution to the myeloid compartment by the deficient cells. So that proves a cell-autonomous requirement for ACD-TPP1, a very profound cell-autonomous requirement for ACD-TPP1 in the maintenance of adult hematopoietic stem cells. With help from David Ferguson, we were able to look at what happens at the telomeric ends acutely after inactivation, so that we get very efficient loss of expression of the ACD-TPP1, but no immediate telomere shortening of any significance. And despite the fact that the telomere are still normal in length, we start seeing an increased frequency of this telomeric fusion. This is a chromosomal prep that is probed with telomeric probes. You can see here that these two chromosomes have aberrantly repaired what they perceive as a DNA damage point and fused to one another. And so that's consistent with the chromosomal instability in the absence of telomere shortening. Now, at the same time as this is happening, you have induction of a very potent p53 damage response. This is indicated here by acutely elevated expression of p21 and NOXA, two classical p53 target genes that are not elevated when we do the experiment in the p50 knockout background. So this is really a p53 dependent response. This would have been predicted by past work. But the surprise was that the cell cycle arrest that we observed here in the G2M phases of the cell cycle, or the apoptotic response that we got based on caspase-3 and several expression, this was completely independent of p53 activation. So the p53 knockout hematopoietic stem cells were not rescued at all from the loss of ACD-TPP1. And this was a surprise because past work from several other groups had shown that p53 deficiency partially and sometimes nearly completely rescues the phenotype of Shelterin dysfunction. This is shown here in a paper by Gary Hammer, where these are two ACD deficient mice, and the mouse on the top also is p53 deficient. This mouse has a large level of rescue of the stem cell dysfunction phenotype in the skin, although at later stages they pay the price by developing tumors. And you can see that here also by this rescue of the hyperpigmentation phenotype in the absence of p53. This is another paper by Maria Blasco in Spain showing that if you inactivate ACD-TPP1 in skin stem cells, the mice die in neonatal ages due to dysfunction of the skin and water leak in the skin, and this is largely rescued by knocking out p53 in skin stem cells. In the case of the hematopoietic system, this is a series of experiments showing what happens to hematopoiesis in the absence of ACD-TPP1 with and without p53. We saw absolutely no rescue of the hematopoietic stem cell function. So hematopoietic stem cells show acute sensitivity to cell autonomous loss of ACDT-PP1. It's much faster than would have been predicted, and it's independent of telomere shortening. It induces p53 target genes and cell cycle arrest in hematopoietic progenitors, but p53 inactivation does not rescue stem cell survival and function. We see p53 independent caspase activation, and in that respect, hematopoietic stem cells seem to differ from other cells, including skin stem cells, underlying the value of testing the role of these Shelterin proteins in real cells rather than in model cells. So the effects of global ACDT-PP1 loss are dominated by very acute telomere deprotection with a unique pattern of consequences in hematopoietic stem cells. I'd like to finish with a few thoughts directed towards the future and highlighting in particular this very nice work by one of my colleagues and collaborator here at the University of Michigan, Jai Krishnan Nandakumar, JK in short, who did this work when he was with Tom Check in Boulder, Colorado, basically focusing on a new function of this gene, this protein ACDP-PP1, not only as a member of the Shelterin complex, but also as a bridge for telomerase recruitment into telomeric ends. Before this work, there was a lot of mystery as to how exactly the telomerase complex finds its target at telomeric ends. How does it recognize that it needs to be there? And what he showed, I'm summarizing the data here in this paper, is that there is a very specific patch in a region of the ACDT-PP1 protein called the OB4 region, which is involved directly in recruitment of the protein component of the telomerase complex. And in parallel, Steve Artandi and colleagues at Stanford basically came up through a different approach to exactly the same conclusion, mapping this region here, the TEL patch, as being very critical for recruitment of the telomerase complex into DNA ends. So what I'm highlighting here is that Shelterin complex have these multiple functions, in part to address one of the problems at DNA ends, the end protection problem, but also to coordinate with the telomerase complex. And I'd like to finish with this last slide. There would be some predictions for the future. What could be the role for Shelterin in human disease, and in particular in Dyskeratosis congenita? Based on our data, I would predict that complete loss of Shelterin function would lead to a very hyperacute phenotype in hematopoietic stem cells, and it is likely something that would be too severe to be observed in Dyskeratosis congenita patients. But I think we could think about a role for other kinds of mutations in the Shelterin genes, such as the spontaneous mutations that Katie identified in mice that would be reducing expression or dysregulated splicing of this gene. So I think there would be a need to screen beyond the initial exon sequencing to look also at regulatory sequences of these genes and splicing sequences of these genes to capture these additional mutations. And finally, I would like to speculate that there could also be a role for mutations that disrupt only certain functions of the Shelterin proteins. For example, only the function of recruiting telomerase into complex and not the function in protection of DNA. I'd like to finish by acknowledging the people in my lab who did this work. Morgan Jones was the student who was involved in the work that I presented today. Jennifer Chase is continuing that work with specific questions about structure function of ACDT-PP1. We had a lot of support from Anne, chief technician in my lab. We've collaborated with the Ferguson lab, very nice collaboration with the Keegan lab, and now with JK's lab. In MCDB, we have an ongoing collaboration with Sharon Savage and at DNCI. Thank you very much.
Wonderful work. Time for one question.
Larry?
Yeah. Would you expand on the clinical phenotype of these Shelterin mutation? What's known in terms of onset, bone marrow failure, and predisposition to cancer versus the other mutations?
I don't know about cancer, but I know that the cases that have been reported have an early onset. And some of them have this Hoyer-Alvar-Haidarson syndrome that I told you about, that has a neurological phenotype as well as cerebral hypoplasia, probably due to the defect in neural stem cells. So this is what I know, unusually early onset, and I don't know about the cancer predisposition.
All right, thank you very much. Our third speaker is Dr. Christen Ebens. She was introduced a little bit earlier. She is our first Immune Heme Fellow and has done a lot of work this year. And she's just going to show you a little bit of it here. But you can visit her at the posters, and you will find her at, I think, 3 different posters?
Just 2.
Just 2, sorry. Okay. So, Christen.
Thank you, David, for that introduction. It's been a really terrific year doing immunohematology with all these wonderful people. And our last speaker is actually my PI for all the research I've done during my pediatric hematology oncology fellowship, as well as now during my immunohematology fellowship. So I have a really interesting patient case from immunohematology clinic that I can tell you about at the poster session, but here I'm going to focus on the research in the lab, mostly with mirroring models of transplant and evaluating the role for Notch signaling in one of the major complications following transplant, graft-versus-host disease. I unfortunately have no disclosures. So briefly today, I'm going to introduce you to one of the major complications of bone marrow transplant, graft-versus-host disease, discuss introductory discussion of what Notch signaling is and why we thought this might be important in graft-versus-host disease, as well as some early studies to show that it's a critical regulator of this problem following transplant, and then a story going down the line to describe this more, identifying the key ligands and receptors of the Notch signaling pathway involved in graft-versus-host disease, as well as some early work looking at the cells that express these in GVHD. So bone marrow transplantation can be very helpful when patients have absent or dysfunctional hematopoietic or immune systems. Physicians are able to provide large doses of chemotherapy or radiation to eliminate the dysfunctional cells, which then allow for the patients to receive healthy cells from donors. This is a terrific therapy that provides an option of cure for a number of disorders, ranging from oncologic diseases to hemoglobinopathies to, in the case of our symposium today, a number of immunodeficiencies. However, broader application has been limited by the severe and fairly frequent side effect of graft-versus-host disease. So briefly, GVHD is mediated by donor T cells in the transplant inoculum that attack recipient tissues. Target organs are pictured here, including the skin, the gut, and the liver, although other organs are certainly affected, and particularly lung can be found as a major complication following transplant. The incidence varies based on the HLA matching between donor and recipient, as well as conditioning regimens and prophylaxis used, but approximately 50% or so of patients receiving an allogeneic bone marrow transplant experience some degree of acute graft-versus-host disease. On a cellular level, GVHD can be described as a donor T cell coming into a recipient in which host antigen-presenting cells, particularly dendritic cells, are presenting self-antigen, which is perceived by the donor T cell as foreign. In the proper setting of co-stimulation and pro-inflammatory cytokines, the T cell becomes activated and goes on to attack these target tissues, leading to graft-versus-host disease. Our question in the lab then was whether or not Notch signaling has any role in this process, and could it possibly be targeted to decrease the rates or the risk of graft-versus-host disease. So why look at Notch signaling? Here are a number of different things we know Notch signaling is involved in. Most of them in regards to hematopoiesis. So the transition from primitive to definitive hematopoiesis is critical to have Notch on board. In fact, absence of Notch signaling would be lethal. There's a bit of controversy about the role for maintenance of stem cells, but perhaps it not just general maintenance, but times of stress, it may play a role. But I think perhaps the most well-studied role for Notch is in cell fate decisions and T cell development in the thymus, where you have thymic progenitors arising from hematopoietic stem cells in the bone marrow, traveling to the thymus to develop into mature thymocytes. And you see here at the bottom, the level of Notch signaling intensity in the thymus is really quite high and required for T cell development up to the pre-T cell receptor checkpoint, after which it drops off. The question we have in lab then is what happens to these T cells in the periphery, particularly in the post-transplant setting? Do they, again, experience Notch signaling in the process of graft-versus-host disease? This is a schematic of Notch signaling, in which in mammals you have 5 different Notch ligands, delta-like 1, 3, and 4, and JAGN 1 and 2 on one cell, communicating with one of 4 Notch ligands on an adjacent cell, and for the sake of our discussion today, that would be the T cell. When ligand and receptor engage, there's a conformational change right near the cell membrane surface, in which previously protected sites become available down here to a series of proteolytic cleavages. The final step here is mediated by gamma secretase. Once these cleavages happen, the intracellular portion of Notch is released. It translocates to the cell membrane, where it takes part in a large transcriptional complex. Prior to the arrival of intracellular Notch, this transcription factor CSL is binding a number of co-repressors, and transcription downstream is inhibited. However, once intracellular Notch arrives, it recruits mastermind-like and a number of other co-activators to transcribe downstream genes. In the lab, we have a number of mechanisms to inhibit Notch signaling. The first of these I'm going to describe to see whether or not Notch has a role in GVHD following transplant is a genetic inhibition here at the level of transcription, in which mice have replacement of this normal mastermind-like with a dominant negative mastermind. This protein encodes just the N-terminal of mastermind, such that it's able to bind intracellular Notch but unable to recruit the other coactivators, and therefore functions as a pan-Notch inhibitor downstream of any ligand or receptor interactions. So this is our basic setup for an allogeneic transplant in mice. So black 6 mice here. Bone marrow from them is transplanted into bulb C mice. They don't just differ in color, but they differ at their MHC, the H2. And then these mice receive different conditions, either wild-type Notch intact T cells, DN mammal Notch deficient T cells, or no T cells. And we follow them for survival then and do clinical graft-versus-host disease monitoring. Here are survival curves from this experiment. As expected, the mice receiving no T cells or lacking the mediators of graft-versus-host disease survive long-term with no signs of GVH and no survival deficits. Mice receiving wild-type Notch intact T cells succumb early to severe graft-versus-host disease, with all mice deceased by day plus 40 following transplant. Remarkably, those mice receiving Notch-deficient DN mammal T cells survive as well as those receiving no T cells, with decrease in clinical graft-versus-host disease scores, as well as decreased pathology at the end of transplant. What's really interesting about these T cells is they seem to expand and proliferate normally following transplant. They're able to respond to tumor challenges, but they also have acquired sort of an anergic phenotype in response to the recipient into which they're placed, shown here by a decrease in pro-inflammatory cytokine production compared to the wild-type T cells, and an increase in FOXP3 positive T regulatory T cells. This is an avenue we're exploring more, exactly why these T cells don't cause graft-versus-host disease, but we were pleased to see that they didn't. However, translating this to the clinic would be rather difficult at this stage, so we took one step back to look at a pharmacologic method of pan-Notch inhibition by using gamma secretase inhibitors to prevent the cleavage of intracellular Notch. I'm not going to show all the data here, but the T cells that were treated with gamma secretase inhibitors exhibited the same decrease in pro-inflammatory cytokines and shift from conventional T cells to T regulatory T cells, but there was some severe on-target toxicity of the GSIs, such that the mice had severe diarrhea and succumbed to death early following transplant. There's a lot of information about why that's so, and I can talk to you about that a little more after if we have time, but GSIs were deemed to be too toxic to pursue as a method to decrease GVHD following allotransplant. Finally, with a unique collaboration with Genentech, we gained access to a number of humanized monoclonal antibodies against a variety of ligands and receptors in the Notch signaling pathway. Investigating these individually, we found that delta-like 1 and 4 and Notch 1 and 2 are the key ligands and receptors mediating GVHD in our model. So to show you this, we used the same setup before, using T-cell depleted bone marrow from black 6 mice, injecting that into lethally irradiated bulb C mice, giving them the same conditions of notch intact, notch depleted, or no T cells, but we added additional conditions treating these mice with antibody against delta-like 1, delta-like 4, a combination of both, or an isotype control for either a short course, just 10 days following transplant, or a long course up to 60 days following transplant. And here are the survival results from that study. The isotype-treated animals are shown in black here, and they recapitulate our previous findings in which mice survive long-term with no GVH when given either no T cells or notch-deficient D and mammal T cells. Mice receiving wild-type notch-intact T cells succumbed early to graft-versus-host disease. We see a gradation in effect with inhibition of delta-like 1 with some survival prolongation, even a bit more with anti-delta-like 4 treatment, but really remarkably the best response with a combined treatment of both, such that these animals, whether given just a short course or a long course, survived long-term, essentially equivalent to those mice not receiving any T cells. And this speaks to the importance of a immediate post-transplant T cell priming event that we're able to stop treatment with delta-like 1 and 4 as early as 10 days after transplant and see this prolonged survival benefit. This is just a picture of the mice. You see here on the left, mice receiving wild-type notch-intact T cells and isotype have signs of graft-versus-host, which in the mouse are manifest as fur loss, skin changes, severe diarrhea, and weight loss. The remainder of these mice, either receiving no T cells, notch-deficient D and mammal T cells, or a combination inhibition of delta-like 1 and 4, all look perfectly normal with intact fur and no signs of weight loss or diarrhea. So we demonstrated that notch is a critical regulator in the process of graft-versus-host disease following allotransplant. Unfortunately, GSIs, and also I didn't show this data, but specific inhibition of notch receptors were too toxic to pursue. But these two ligands, delta-like 1 and 4, collective inhibition of them seemed very effective and tolerable to decrease GVHD in mice. What we don't know is where those ligands are coming from. So this harkens back to the initial immune synapse model in which you have a donor T cell and an antigen-presenting cell setting up the scene for graft-versus-host disease, but where do these notch ligands fit in? We could suggest that they're present on the donor antigen-presenting cells, perhaps those that are able to survive conditioning regimens long enough to prime donor T cells. They could be on donor antigen-presenting cells that come in from the donor inoculum. But what's been interesting to us is the idea that these could also be present on non-hematopoietic antigen-presenting cells within the host. Those could include vascular, lymphatic endothelial cells, or stromal cells from the lymphoid organs. To investigate this, we did a number of serial transplantation models in which we used conditional knockouts. So we have mice that have floxed alleles for delta-like 1 and 4 that can be excised with the activation of MX-CRE, which is specific to the hematopoietic system. So when we dose the mice with poly-IC, they have a large interferon release, and these delta-like 1 and 4 then are excised from just the hematopoietic cells in the mouse. In order to create a large cohort of these mice and to avoid any CRE toxicity, we then use these mice as bone marrow donors in an autologous transplant and allow these mice to reconstitute. So these mice in particular are lacking delta-like 1 and 4 expression strictly within the hematopoietic system. It's present in all the other cells that might be important. So after we checked them for excision to make sure that they are who we think they are, we then use them in a secondary transplant, receiving bone marrow and or T cells from a bulb C mouse. And these mice are, again, dosed with either isotype or anti-delta-like 1 and 4 antibodies for a short course to see how they do with survival in graft-versus-host disease. Here you see the results of that study in terms of survival. The solid green line is the condition in which the mice are lacking delta-like 1 and 4 expression within their hematopoietic system. If the host APCs of the hematopoietic system are indeed critically important for graft-versus-host disease, we would expect these mice, even when treated with isotype, to have protection from GVHD, but unfortunately they did not. The groups strictly separated based on whether or not they received exogenous systemic inhibition of delta-like 1 and 4. So it appears that there's no survival benefit when the host hematopoietic antigen-presenting cells are lacking delta-like 1 and 4. To move on to assess the donor, we again did the same setup to create mice that were lacking delta-like 1 and 4 expression in the hematopoietic compartment, but this time used them as donors into bulb C recipients. Instead of evaluating long-term survival, we looked at our short-term outcomes, including pro-inflammatory cytokine production and T-regulatory cell production. And we found here again that there was really no difference. These plots are a little difficult to see. So the two on the left are your Cre-negative or wild-type bone marrow chimeras that have intact Notch signaling throughout. On the right two here are the knockouts, the delta-like 1-4 knockouts that are lacking in the donor, the hematopoietic delta-like 1-4 expression. And then this is GD-treated, delta-like 1-4 antibody-treated, GD-treated, delta-like 1-4 antibody-treated. And you get a very similar pattern to before where you see no protection when the host hematopoietic cells are lacking delta-like 1-4 expression, but significant protection, decrease in cytokine expression when you inhibit with exogenous delta-like 1 and 4 administration. And this is across the board in a number of pro-inflammatory cytokines. So moving forward, we would like to eliminate delta-like 1 expression in both the donor and host, but to do this in an allogeneic transplant setting, we need to get our mouse model with our floxed alleles onto a different background. So we're currently in the process of back-crossing these floxed mice onto a bulb C background so we can set up a transplant and that mechanism. We have a whole other set of data looking at a surrogate model of another type of cell that's Notch dependent that arises post-transplant that's consistent with these findings. And unfortunately, I didn't have time to show today. But ideally, what we would like to find is a Cre driver that's specific to a host non-hematopoietic antigen-presenting cell type, so we could show that eliminating delta-like 1 and 4 expression in those cells is able to protect from graft-versus-host disease to confirm our hypothesis. There are a number of folks to thank in the lab. Yvonne, who you just heard from, has been an excellent mentor, and pretty much everyone in the lab has taught me everything. I came in not doing research before at the bench, so this has been really excellent experience. And then, as I mentioned at the beginning, I've had the pleasure of working with Kelly and Jim and everyone in our immunohematology clinic. And I also appreciate the support of a number of other folks here today, particularly the Vidara Fellowship funding. Thank you.
Thank you. Time for one question.
Dr. Boxer.
Beautiful presentation. An alternative approach would be to understand the biochemical pathways involved in Notch signaling that might be amenable to drug inhibition. Have you pursued that line?
So a previous grad student in our lab who was studying immunology specifically did some biochemical work to try to understand what's going on with those Notch-deficient B and animal T cells, and looking at some of the energetic pathways that we seem to sort of, our cells seem to mimic their profiles with some upstream changes suggesting that the cells aren't signaling all the way down to the pro-inflammatory sort of cytokine production levels. That hasn't been pursued too much lately, but we started looking at that.
Thank you very much. Our last speaker for this session is Dr. Craig Byersdorfer. I was hoping he would make it. He's actually on service because all of our other transplanters are actually at a conference right now. So I've had the privilege of working with Craig. He was one of our Ped Hemonc fellows who actually we were lucky enough to keep for a little while. Unfortunately, I think he is leaving pretty shortly, but he's going to show you some of the great work that he's done, also looking at work with graft-versus-host.
And so I'd like to thank the organizers for the opportunity to present my research today. I'm going to tell you a little bit about allogeneic T cells and how they increase their reliance on fatty acid metabolism, which then allows for some selective metabolic targeting. Like Christen, I don't have any disclosures, unfortunately. And she did a really nice job of setting up the background, so I'm not going to spend a lot of time talking about this, but just a couple of slides on this. Allogeneic bone marrow transplantation remains a curative option for bone marrow failure syndromes and some types of leukemia. Unfortunately, as Christen pointed out, bone marrow transplantation is complicated by graft-versus-host disease, where donor T cells attack and destroy host tissues. This one you should recognize from her talk. It was nice that we got some synergy on this. But a lot of times these patients are affected by a skin rash, liver problems, and then as you see in this last picture here, profuse and watery diarrhea and attack of the gastrointestinal tract. Now, we have come up with some innovative ways to eliminate or immunosuppress the T cells, which decreases GVHD, but this obviously comes at the risk of heightening the risk of infection and increases the likelihood of graft failure. So the sort of holy grail of bone marrow transplant research over the last 20 to 30 years is really to find a selective elimination of the pathogenic or GVHD-causing T cells with preservation of physiologic T cell responses. And I sort of went about this in a slightly different way than the conventional people were thinking about it, and I wanted to look at it sort of from a standpoint of what are the cellular energy requirements of the responding T cell, and see if we could separate the responses in this fashion. And that'll be taken through in this next cartoon here, where we're comparing a physiologic T cell response perhaps after a syngeneic bone marrow transplantation versus a T cell response during a graft-versus-host disease reaction. And so during a physiologic T cell response, the T cell might be responding to some growth factors that are within the animal or within the human, undergo modicum of proliferation, and have some baseline energy requirements. In contrast to this, in a T cell that's being activated during GVHD will also be responsive to some of the same growth factors. But in addition to that, will be stimulated by antigen-presenting cells in the host, both hematopoietic and non-hematopoietic, as Christen pointed out. They'll also be influenced by the cytokines, inflammatory cytokines that are produced in the surrounding milieu. In addition to having just one antigen-presenting cell, though, there will be multiple antigen-presenting cells that are stimulating this T cell to a very high degree. This high degree of stimulation and proliferation will then require that the cell have that cell will have a much higher energy requirement, and then will therefore have to make changes in order to keep up with the energetic demands based on this high level of stimulation. And so my thought was perhaps based on this difference in these energy requirements between a physiologic T cell response and a GVHD T cell response, we could identify pathways that are present in the GVHD T cells that would allow for their selective inhibition or targeting. And this just recapitulates the findings that I had on the last slide, again showing that we think that the GVHD T cells are going to have a much higher energy requirement. We know from the literature that under a physiologic T cell response that a lot of these T cells will use glucose as their primary nutrient. And my question was really then, what is being used as a nutrient by the graft-versus-host disease T cells? And what I'd like to try to convince you of is at least at some level, these T cells are using fat, and that this may allow us to selectively target these cells. One piece of sort of methodologic data that I want to show you, because it comes up in a lot of the slides, and so I want you to be able to follow along. And that is how we measure cell division in vivo when we do these mouse transplants. And so what we do is we take the T cells and we label all of the T cells prior to the bone marrow transplant with a cell division dye. That's shown here. And so all of these cells have a high level of the dye to start with. And they're marked for a specific marker. In this case, it's CD45.1, which is on the y-axis, and that just marks our donor T cells. As the cells divide, the dye content decreases. So every time you see a division, the dye content decreases by 50%. And what this allows is it allows you to see how many times the cells are divided. So in a GVHD animal, you can see that the T cells divide many, many times. And this is actually done over day 7 that we analyze these cells, but already by day 4, the cells have divided, as shown here, at least 8 or 9 times. And so they're undergoing very significant stimulation. What this also allows us to do is it allows us to separate well-divided and minimally divided populations of cells and see if there are differences in a metabolic phenotype between the well-divided and the minimally divided cells. So the first thing that I wanted to ask was whether or not T cells that are undergoing graft-versus-host disease, whether or not they have an increase in their transport of fatty acids. To do this, I used a fluorescent fatty acid analog called BODIPI to assess fatty acid transport. In these pictures, what you'll see is you'll see cell division marked on the x-axis and the amount of fatty acid transport on the y-axis. If you take naive donor T cells prior to the transplant that haven't been labeled with any division dye. They're not positive for the division dye, and they take up a baseline level of fat. Now, some of this just may be the artifact of the system we're using as well. Again, this is now T cells from a GVHD animal. They have a high level of dye. But what you see is that as those cells divide, they actually increase their fatty acid transport, and it only occurs in the well-divided cells. So as soon as the cells go through more than 8 divisions, they start to increase their fatty acid transport. If you draw an arbitrary line to show how much fat they're taking up, you can see that about 40% of the GVHD T cells are transporting fatty acids, whereas only about 3% or less in the naive cells are transporting fatty acid. You can actually look at this in multiple animals, and this becomes statistically significant pretty quickly, comparing the amount of T cells that are positive for BODIPI in GVHD versus naive T cells. So this appears to indicate that the cells are at least taking up the fat. Now, that doesn't tell you that they're actually oxidizing it or using it for energy. It merely means that they're taking it up. Maybe they're turning it into membranes. Maybe they're doing other things with it. So the next question became, are they actually turning it into a functional energy equivalence? And we measured that by looking at fatty acid oxidation in T cells. And so what we do is we take the T cells out of the animals at day 7, and we incubate them with palmitate, which is a free fatty acid. In this case, the palmitate has been labeled with tritium. As the T cells take up the tritiated palmitate and begin to oxidize it, they turn it into tritiated water, which you can measure at the end of the assay. And so by looking at how much tritiated water is produced, you can get a sense of how much oxidation is occurring in these T cells. And so similar to what we see with the fatty acid transport, you're seeing about 3 to 4-fold higher levels of fatty acid oxidation in the cells from the GVHD animals. And so at this point, you'd say they're capable of taking up more fat, and in addition to that, they're also oxidizing more of it, so turning it into energy equivalents. Because I don't have time to show you, there's a number of other studies we did at this point looking at the enzymes that control the fatty acid oxidation, as well as some intermediate pathway metabolites, and all of those are also elevated. And so there's some additional evidence that I'm not showing that it really shows that these T cells are able to oxidize an increasing amount of fatty acid. So, but the real question sort of was whether or not blockade of fatty acid oxidation would actually affect the allogeneic T cells. And the way we did that is we set up an allogeneic bone marrow transplantation on day 0. And on day 6, we treated the animals with a compound called atomoxir, which irreversibly inhibits fatty acid oxidation. We then looked at the animals on day 7 and analyzed the T cells that were there to see if they were selectively inhibited in the animals that received atomoxir. That's shown here, where on the y-axis we're looking at the donor T cell number on day 7. And you can see that in the atomoxir-treated animals, there's about a 30% reduction in the total number of donor T cells. If you look at the remaining T cells and ask if they're in the process of dying, you can see that the annexin staining on those remaining T cells increases. And so not only do you have a decrease in the T cell number, but you also have an increase in annexin positive staining on the remaining T cells, which means they're probably undergoing apoptosis and that more T cells will die in the near future. Then the question became, well, you can decrease the number of donor T cells, but does that have any clinical implications in these models? And here what we're showing is that atomoxir was given to the animals every other day starting on day 5. Now, it's important that we start on day 5 because at that point in time, the GVHD has already started to develop. So we're not using this in any sort of prophylactic sense. We're really using it as a form of treatment. So that after the GVHD has started, can we actually inhibit the GVHD by blocking fatty acid with atomoxir? And then we measure the animals on day clinical score from weeks 3 through week 8. And we also take a look at their weight loss. And as you can see here on this graph, the animals that have been treated with PBS have higher clinical scores than the animals that have been treated with atomoxir. Again, this is done after the atomoxir has already gone into the animals have been treated, so this is a long-term effect of the atomoxir treatment for 2 weeks. In addition, animals that were treated with atomoxir had less weight loss and actually gained a little bit of weight over the course of the transplant, which is, again, statistically significantly different from the animals that were treated with the PBS control. To verify these findings, we went back and began treatment with a second fatty acid oxidation inhibitor. In this case, recipient mice were treated daily with a compound called ST1326, which is a reversible fatty acid oxidation inhibitor. And again, we gave this compound from day 5 through day 19 post-transplant, indicated here by the red line. You can see here pretty clearly that the animals that received the 2-week course of daily ST1326 treatment had a markedly increase in their survival post-transplant compared to the PBS treated control mice. So it certainly appears that fatty acid oxidation is occurring in the allogeneic T cells, and that it forms a therapeutic target that you can eliminate the allogeneic T cells. However, if you remember back to the beginning slide, what we really want to do is we want to have something that separates the physiologic response from the allogeneic response, and at this point I've shown you data only on the allogeneic response. So the natural question, if you've been following along, is, well, what happens to the syngeneic T cells or the physiologic T cells during this process, and are they affected by fatty acid oxidation inhibition, or do they upregulate fatty acid transport? In the way so the question is, do T cells rely on fatty acid oxidation during homeostatic reconstitution? So we use a syngeneic transplant to address this. And again, we're going to look at cell division versus fatty acid transport. Again, if you look at the GVHD animals, we're going to compare that to a syngeneic transplant, sort of like an auto transplant for those of you in the clinical realm, where no GVHD is present. And you can see that, again, in the GVHD animals, about 50% of the cells have that nice uptake in fatty acids as measured by BODIPI, and a much lower level of the cells in the syngeneic model transport the fat. And as evidenced here, again, this is statistically significant with the GVHD T cells showing a much greater increase in their fat uptake. And then the question became is whether or not the syngeneic T cells would be inhibited by the fatty acid oxidation inhibitor atomoxir. So we went back to a similar experiment again, set up a syngeneic bone marrow transplantation on day 0, treated with atomoxir on day 6, and analyzed the T cells on day 7. Again, in the GVHD setting, when you treat with atomoxir, you get about a 30% reduction in the number of donor T cells. However, in the syngeneic setting, despite the treatment with atomoxir, you don't get any decrease in the number of T cells, meaning that the atomoxir is really not affecting those cells. And that goes along with changes. We don't see the changes in fatty acid transport. We don't see fatty acid oxidation occurring in these cells either. And so all of this data is consistent with the syngeneic T cells undergoing homeostatic proliferation, not relying on fatty acid oxidation, not being inhibited by fatty acid oxidation inhibitors. And so the overall conclusions from these studies are that GVHD T cells upregulate fatty acid transport, they increase fatty acid oxidation, and are sensitive to fatty acid oxidation inhibitors. That the changes in fatty acid metabolism that we're seeing in the allogeneic T cells are not seen in T cells undergoing homeostatic reconstitution. For example, in this case, I've shown you proliferation after a syngeneic transplant. And that reliance on fatty acid oxidation actually represents a novel metabolic paradigm for effector T cells, because if you look in the literature in terms of what people think effector T cells use, a lot of people say it's glucose, or the process of glycolysis, and here we're showing that there's a clear dependence on fatty acid metabolism, fatty acid oxidation. It also suggests that there's a potential therapy for GVHD and other T cell-mediated immune disorders by inhibiting the fatty acid metabolism or fatty acid oxidation pathway. In terms of future directions for these studies and things that we're exploring in the lab currently, one of the big areas of emphasis or research right now is, as Larry alluded to in the last talk, is to explore the molecular mechanisms upstream of fatty acid oxidation and trying to find out what might be driving the fatty acid oxidation in the allogeneic T cells. The second is to do a more intensive investigation of the therapeutic potential of additional fatty acid oxidation inhibitors. And the third thing, which I'm really excited about and to get going on, is to verify that the fatty acid metabolism is actually altered in human T cells during GVHD. And so the thought there would be to take samples from patients with GVHD and those without and compare their T cells and see if any of the pathways that I'm detecting in my allogeneic T cells from my animal models are present in the human system. So with that, I'd like to close just acknowledging the people that helped make this work possible. I'd like to thank Dr. Ferrara, who unfortunately can't be here right now. He's at the ASBMT conference in the airport in Dallas, Texas. But he's been invaluable in terms of mentor support and resource support over the years and really let me go my own direction with this project. other members of the Ferrara lab who made important contributions to this project, including a talented postdoc, Victor, Stephanie, who's the lab manager, Jacob Swanson, who's a very talented undergraduate, and my recent hire, Jeremy Grecken, who's helping me with current pathway exploration. Other members of the Ferrara lab who are also present in the audience, and I think their attendance today. And this is the grant support that I got to work on this project, including a recent Hyundai Hope Grant Award and the Nancy Newton Loeb Award for pediatric cancer research from the University of Michigan. So with that, I'd be happy to take any questions related to this topic.
Thank you very much. I have to say, to the dismay of my dietitians, I have always limited lipids in our graft-versus-host disease patients, so you've now given me very good reason to actually say that it's an important thing to maybe do. Yes?
Along those lines, has there been any clinical data looking at obesity and increased rates of GVHD?
No, there's not.
I would love to get a clinical colleague that would be interested in exploring this issue with me and going back and looking at how BMI would affect, patients that have GVHD, whether or not BMI would track with the severity of GVHD that these patients experience, but that hasn't been done yet. I have done.
We actually are looking at that right now.
Okay.
Yeah.
So I have done some animal experiments, and the experiments, animals that are put on a high-fat diet for as little as 2 to 4 weeks ahead of the transplant have much higher rates of graft-versus-host disease than animals that are not. So that could be a number of, lipids or high-fat diets are also very inflammatory, so it could be simply from that. But yeah, there's definitely some intriguing evidence from the preclinical side that would be.
Well, I'll take a couple.
Fairly transient benefit of the metabolism inhibition in terms of clinical use for your survival. Just you'll endure around some days a week. How do these mice fare beyond that time? Do they succumb to the disease as well as the upfront untreated animal? And there you probably have some at least physiological correlates, muscle tissue within metabolism, brain as well. Are there any kind of off-target, off-GVHD target effects, adverse effects?
Yeah, that's a great question, and some of that we've sort of done a limited analysis on that. So we've looked at things like free fatty acid levels, triglyceride levels, cholesterol levels, other things in the livers themselves in the setting of AST, ALT, some of these other things to look for liver damage in the mice that were treated with etomoxir. And we couldn't see any differences between the mice that were treated with etomoxir and those that weren't. And I will point out the clinical scores that were shown there, I didn't do a great job of explaining this, but these were actually taken, animals were treated for 2 weeks, and then those clinical scores were taken sort of weekly up to 4 and 6 weeks afterwards. And so they sort of represent a continuation of improvement in those animals well after the time that they had gotten the etomoxir treatment. So it doesn't appear you need consistent etomoxir treatment or consistent fatty acid oxidation inhibition in order to get the benefit. What you need to do is you need to stop the T cells when they're initiating the disease and they're very activated, and then you seem to have long-term benefits even after you stop the etomoxir treatment.
And a 50% mortality in the animal, correct, at day 40. That's still your long-term survival. Day 40 and probably there's no follow-up after. Does this mean that kind of treatment will just delay the onset of the disease, or disease assumes different phenotype?
Yeah, it seems so far in my hands, although you're right, I need to go and evaluate this further, but it seems in my hand that those mice that are treated seem to do better overall long term, so that if you look at day 60, that the mice that are surviving, there's only 2 mice that are surviving in the PBS treated mice, but they still look worse than the 50% of the mice that are surviving in the etomoxir treated. So it appears to be a long-term benefit in this. But I mean, the other challenge here is really trying to define what inhibitor I want to use going forward to really test this, because all of them, like the etomoxir, has other side effects that are unrelated or off-target related to the fatty acid oxidation inhibitor, and so going to the second fatty acid oxidation inhibitor may be the way to go. I just haven't had time to explore it as fully yet, but that's a great question.
All right, I want to thank all of our speakers this morning. This has been a great opening session, and it's time for lunch. There's a box lunch, right? There's a box lunch outside, and please take your lunch to the poster sessions. That we have a lot of posters, and they will all be happy to talk to you. So thank you all very much.
And anybody that has a question, I'm happy to take them.
Thank you.
Yeah.
Great job.
Thanks.